All right, well, hello everybody. I'm going to talk a little bit today, low back pain and sciatica. Normally this is done in a live workshop format with COVID-19 and all the precautions that we're doing. We decided to do this via a webinar. Nice thing here is you'll be able to see a lot of my presentation a little bit better. So let's just dive right in. Some of the format will be just a little bit different than what you might normally see, but think about your own situation. Have you had any back pain or sciatica type symptoms in the last 30 days? I know that I have. I'm an owner of a back that has to be taken care of a little bit from time to time. I'm not always the best student or patient of doing what I need to do for mine, but it's something that I deal with as well. So hopefully I can relay a little information for you that might be helpful. So normally, what I'll do right now in my live workshop is demonstrate what I call a 5-minute miracle. Now, obviously in this scenario, I can't do that, but what the 5-minute miracle means, we normally, when we're working with a patient comes in to see us, we're looking at 3 phases of healing. The first being we want to quickly and drastically reduce pain that we're dealing with, regardless of where it is. In this case, it's the low back or sciatica type symptoms. But that's what we look for, number one. The second phase of healing would be to restore motion and begin to restore strength. And then thirdly, we're going to look at trying to restore functional activity, getting back to normal activities. So it's that first phase that we're talking about and creating that miracle, if you will, that wow moment that lets us really decrease that pain symptom that we're dealing with. We got a lot of different ways that we can do that, and we'll talk about that a little bit more. But that's what I normally demonstrate during the 5-minute miracle. So let's jump right into what is sciatica. So sciatica I'm going to call it, it's a garbage can term. And so what does that mean? Well, sciatica to me might mean a little bit different than it might mean to somebody else, say in the northern part of the country. It doesn't have a true definition of what it means. For some people, sciatica means pain that's shooting down the leg. For some people, sciatica means pain that originates just away from the midline of the low back through here. Depending on where you are, it kind of defines what sciatica means. For our definition, I'm going to refer to sciatica as pain that is just away from the midline, right in this general area where the little red dot is pointing, in between the 2 hip bones, but just off to the side. And then for pain that refers or radiates down the leg, we'll just simply refer to that as radiating pain. But excuse me, but that's my definition of sciatica. And so when we talk about that, we want to talk a little bit about the anatomy that we're dealing with. Sciatica obviously comes from the word sciatic, which is the sciatic nerve. So the sciatic nerve is the longest and largest nerve in the human body. It originates it has branches that come from the 4th and the 5th lumbar vertebra, as well as the 1st, 2nd, and 3rd sacral region. And so all 5 of those nerves come together and form this big nerve that runs out between, as you can see right over here, between the bone where we sit, our sit bone or our butt bone, and then the side of the leg. And so that's where we feel some of that can shoot down the leg on the backside right there. So that is a little bit about what the sciatic nerve is. Again, just another picture that demonstrates the different branches that make it up from 4, L5, S1, 2, and 3. And then this is looking from the front. And so then they exit through the pelvis and then go out the back, again, between our sit bone and our upper leg bone. So in a live workshop, I'm going to hand out the participants that come a little worksheet that has some questions and answers on there. And so in this worksheet, again, we've talked about this. The sciatic nerve is the largest and the longest nerve in the human body. Your body has 2 sciatic nerves, obviously 1 on either side. And the sciatic nerve travels from the back and it goes down the back of the leg and into the foot. So a sciatica sufferer may experience pain, numbness, or tingling in the leg, but it's caused by a problem in the back. So a little bit about me. Who am I and how did I come to specialize in dealing with low back pain? Well, before we talk about my education and so forth, like I said, I'm an owner of a back. I have my original back injury was when I was 14 years old. It happened from a weightlifting issue, bad form, and I still remember exactly when it happened. I basically at that point herniated a disc, and we'll talk about the different types of herniations as well in a little bit. But I herniated. I know it was between L5 and S1, and over time, that has given me problems from time to time. The pain that I dealt with would be severe. I've found ways of dealing with it as a younger person. As I went through my education piece here, I graduated from physical therapy school out at Texas Tech in 1994. I learned a little bit more about what I could do to treat my own back pain during that time, so it became less of an issue. Maybe once every couple of years, I would have a fairly significant back issue, and it would keep me down for about a day or two. And I learned what I could do to take care of it. We'll talk about a little bit more, some different ways that I take care of it now that really significantly improve my ability to do what I need to do. In 2012, I completed my doctorate of physical therapy through the MGH Institute in Boston. Some of the achievements: I am the author of the Haynes method of neuromuscular dry needling. When we talk about the 3 phases of healing and getting that 5-minute miracle, the dry needling piece is something that we use quite a bit, and having a significant reduction in that sharp, hard pain that we deal with. I basically I have 3 different certifications in dry needling, and felt like the different teaching that was out there didn't go far enough. So I created and authored and copyrighted my own approach to dry needling. I teach throughout the state to different clinicians on how to dry needle and an effective approach for that. And I'm the senior instructor for the Dry Needling Professional Training Series. And at times I do some guest collegiate lecturing. Clinically, I've treated or supervised over 500,000 patient treatments. With my dry needling, I've seen over 30,000. These are old numbers, so it's quite a bit higher than that, but 30,000 patients with probably 150 to 200,000 needles through this time frame. And this has all been the dry needling within the past 6-7 years. So let's talk a little bit about getting back to normal and some of the first steps. One of the things we really want to know about is your pain reproducible? If your pain is reproducible, there's hope. It should be. If it's reproducible, we can get rid of the pro, and then it should be reducible. And that becomes important. So whether it's in the low back, whether it's a sciatic type problem, almost every, and I'm going to say every pain that we have, as long as it's musculoskeletal, then there is some movement that we do that can make that pain worse. Usually there's a pain that can make it better as well, but what we want to be able to find out is is there a movement or an action that we do that makes that pain worse? If so, that's what we're looking for. If we can find that movement that makes that pain worse, then there's a mechanical issue, and we can make some changes, and we affect an improvement with that. So if your pain, numbness, or tingling is reproducible, then it's reducible. So normally I'll ask everybody in the past 30 days, the worst pain that I've had was what, how much? So we look at pain, lots of different ways of doing it. Typically we've all seen the 0 to 10 scale. 0 is no pain. 10 is our worst imaginable pain. And the idea is, over the past 30 days, how bad has it gotten for you? And just think about that. I know for me, I've had a pretty good month. My worst time is usually in the morning when I get out of bed, and maybe it's been a 4 out of 10. 10's your worst imaginable. For me, fortunately, I get up, and if I do my exercise, my homework the night before in that morning, it's usually not bad at all. Like I said, I can be a bad patient as well. I'm a human being, which means I kind of forget sometimes. And so that's my worst level, is about a 4 over the past 30 days. And then you also want to think about when you have this pain. Do you have it when you're sitting, when you're standing, when you're walking, or lifting, getting in and out of the car. Like I said, for me, it's getting in and out of bed is usually the biggest issue. For some people, it's walking long distances. So think about what activity it is that you do that seems to be the thing that aggravates that pain that you deal with. And so now just some random conversation about a cause of a problem. Now this is about any problem. There are things that we can do when we have a problem. I'm going to use an analogy of potholes in the road, and I'm going to compare that to the low back and sciatica. So very first thing that we normally do is we ignore it. So I live on part of town that's doesn't seem to see a lot of road work. It's an older neighborhood, so I think maybe we just don't get enough attention. I don't know what the problem is, but we tend to have a lot of potholes over there. So we can ignore that, and and nothing changes. We can swerve around the potholes, and it can go away temporarily. And so in a situation of low back pain, it hurts. We can ignore it, and it might go away. We ignore it long enough, ultimately, we may have to deal with it. So that's the first thing that we can do, is just simply ignore it. Second thing is we can try to alter it. So in the pothole analogy, we can come in, and the city or the county can come in and they can pull the truck up and get a few shovelfuls of asphalt and tamp them down there. And that's going to last a little while. Ultimately, we all know that that's just a patch. It's not going to last forever. With the low back, the analogy there is drugs, injections, and surgery. So we can alter it, and the drugs and injections and even surgery definitely will alter the problem. The problem is usually when we're dealing with a back issue, we normally know that there's a mechanical piece that's causing that. And so if we don't take care of that mechanical change, the drugs are going to dull the pain, or the injections. Surgery can take pressure off of a nerve, but if it's being compromised because of, let's say, poor posture, until we deal with that posture or the tightness issue, then that pain is, and I've seen it clinically for years, that pain will come back. So we definitely, altering is another option, but ultimately, the third thing and the most important thing is we need to handle it. And so, again, on our pothole, our road work analogy, again, really the only way to get that road in good shape again is to repave it. And so with the low back, it comes down to getting some natural treatment, and really it's learning how to manage your symptoms. Again, there's going to be a mechanical issue that we see with every back problem. Interestingly, the problem with men tends to be more of a problem of tightness, and especially in the hamstrings and the back of the leg. And so there are different things that we look at to see what is the mechanical problem that's creating this issue. And so going back to this worksheet that you don't have in front of you, things to do when faced with a problem. The number one biggest mistake low back pain and sciatic sufferers make is they ignore it. And the three things that you can do about pain and sciatica right now, obviously, you can ignore it, you can alter it, or you can handle it. And so let's talk a little bit about the three main causes of back pain. Now let's have a quick discussion of imaging and what normal imaging looks like. So in this picture that you see, we're going to look at, let's see if I've got that in. Okay, so we've got vertebra, disc, and spinal cord. The vertebra are the larger rectangles that you see through here. Matter of fact, here is L5, here's L4, L3. In between each of those vertebra are the discs themselves. And so you can see they've got nice, good looking space in between. No significant abnormalities to be seen. When we look in the central canal or the spinal canal, where the spinal cord is, you don't see any significant bulging or anything crazy going on in there. And so this is fairly much what we'd expect to see out of a normal image. In this particular picture, this person is standing actually looking to the left. So they're facing this direction over here. And the bones back here are just those pieces that you feel if you feel down the middle of your spine there. And so that's what normal looks like. So again, the three main causes of back pain. Number one is the bulging or the herniated disc. It's the HNP, the herniated nucleus pulposus. You don't have to remember that, but the bulging or herniated disc, which we commonly think of. So when we look through a little diagram, the yellow represents the spinal cord right here. The vertebra sits out over here. And here's the spinous process there on the backside. Again, similar to the previous picture, this person is standing looking this direction over here, and this is the backside. In between each of the vertebrae is the disc, and you can see nice space in between. And so the bulging disc, number one, the bulging disc, most of us are going to have a bulging disc. If we've got a back issue and above a certain age, we're going to see some bulging. And what that looks like is on the backside of this disc, it can get thin. We can have excessive pressure, and we will see just a push coming out through the backside of this disc. The problem is it can impinge on the spinal cord right here, and we can't see this in this view, but running off the spinal cord between each vertebra is also the nerve that comes down to form the sciatic nerve. And so this bulge, if it's in the center, if it's off to one side or the other, can actually impinge on one of those nerves. So the bulging disc is one type, a herniated disc. And in this case, the annulus. So a disc is made up of two basic pieces. The annulus fibrosus, which you don't have to remember that, is on the outside, and the nucleus pulposus is the inner side. So if you think about the disc like a jelly-filled donut, it's got a nice, tighter, tougher outer shell, and then on the inside is the jelly. Well, with a herniated disc, that outside annulus starts to break down. It gets a little bit thinner. The collagen gets a little thinner, and so it gets a little bit easier with pressure for that jelly to push out a little bit there. You can also have what's called a ruptured disc, and this is pretty rare, but a ruptured disc, this piece right here of the annulus will actually open up or fissure, and the jelly can actually enter into the spinal canal through here, impacting into the lining of the spinal cord. Again, that's fairly rare. And then the last type of a bulging or herniated disc is the sequestered disc. Now, this is extremely rare. Usually a ruptured or a sequestered disc. Decent odds, those folks may have to have surgery. Sequestered disc, probably more than likely. So what happens here is this ruptured disc has pushed a little of the jelly, let's say right out in here, and then it's actually broken off away from the disc itself. So we've got just loose, free-floating disc material floating around in there. If we've got that, or even the ruptured disc, there may not be a whole lot that we as from physical therapy standpoint can do with that. Still possibly worth a look and a try depending on what kind of symptoms you're dealing with. But if you're just dealing with the bulging or the herniated disc, the nice thing there is there's hope. There are things that we can do to change that. So looking at some more imaging of the bulging or the herniated disc, on the picture here on the left is a picture of a bulging disc. Now this is at L4 and L5. As you can tell, now they've actually got some stuff up pretty high too. Just now noticed that. You come down, decent space in between the disc. This one, the space is getting a little bit tighter, and you can see that disc is actually pushed out a little bit into the spinal canal. It's not very significant, but it's a little bit. And so we'd consider that to be a bulge. On this image to the right, you can see that bulge is actually pushed out just a little bit further. And in that case, the difference between a bulge and a herniation, it's semantics, it really is. But a herniation is going to have a little bit more of a protrusion into that spinal canal. So who is the person who will be dealing primarily with a bulging or herniated disc? Well, the people who originally will get a herniated disc is usually a person who's 35 years of age or younger. We do still have them at an older age, And we'll talk about it in a second. At that point, that herniation has changed a little bit. But onset of a herniated disc, it's a younger person's condition. These folks tend to have more pain when they're bending or lifting. They have less pain if they stand up tall. And a lot of times this pain can radiate down the back of the leg, even all the way to the foot. And the most common level of having a herniation is at L4 and L5. The mechanics of how God built this machine is that is the most susceptible level to herniation and injury. So if we take 100 people, just random people, and take 100 MRIs of those folks, and let's make them 50 years old. The percentage of those folks that have a bulging disc, I mean, take a guess, if you will, what the percentage you think that would have a bulging disc, just random people, not people going to see the doctor or anything. The number is 80%. So 4 out of people, random people over the age of 50 with the MRI are going to have a bulging disc. And the very interesting thing is those folks also have no symptoms. So the take-home message there is we can have a bulging disc, we can have a herniation, and not even have pain, not have symptoms, not have any weakness. So we have to be cautious with our imaging and what that means. And so the second cause of back pain is what we'll just call stenosis or arthritis. The technical term is degenerative disc disease. Again, don't have to remember that. So what happens here when we look at the image, this diagram. So you'll notice that we've got the same basic structures, the vertebra on top and bottom, disc in between, the spinal cord running down. But what's happened is these funny little triangles on either side is with age, with mileage, with wear and tear, with bad mechanics, what tends to happen is we start to develop lipping, or, I mean, for lack of a better term, they're bone spurs that develop they can develop all the way around the vertebra themselves. And as a consequence, we also tend to see that the height of the disc itself right here tends to get a little shorter. Well, what tends to happen when that happens is we talked about the spinal cord running up and down here, and we talked about nerves exiting through the foramen or the hole right here. Well, now we've got this disc bulging out a little bit. We've got bone spurs, and we've got a shorter space between each vertebra. So all of a sudden, we've got less space for the spinal cord and for the nerve coming out. And so that's what we tend to see with stenosis. Odds are, if you have that, you're going to be over the age of 50. Most of the folks that come to my workshops are 50 years of age or older. We have some younger folks that show up, but this is the condition that affects most of the people that we see in our workshops, and clinically as well. Again, it can happen at a younger age, but this stenosis business, the arthritis, over the age of 50. Here we're going to tend to have increased pain with standing and walking. These are the folks that, it hurts if you're standing for too long or you spend a lot of time walking, and you find that you sit down and all of a sudden that back gets to rest and it feels better after you sit down for a little bit. Here the pain can be in the buttocks and it can travel down the side of the leg. Interestingly here, this is frequently mistaken as hip pain. So a lot of people will come in to see me and they'll complain of what they call hip pain, and they reach over to the side or onto the back side of their hip. Well, that's typically an arthritis or a stenosis problem. People with true hip pain feel it more on the front side of the hip. That's where the ball and socket issue comes into play. So that pain over on the outside is a thing. Also, these folks, if they lean forward, it will open up the foramen or the hole where the nerve comes out right here. You get less pain with that. If they stand tall and extend and close this down even further, it tends to cause more pain. And so looking here at some examples of imaging here. As you look at the image on the left, we talked about that lipping or the spurs. You can see a significant amount of degeneration that's taking place. At each level at the disc, you see a lot of encroachment into the spinal canal itself. And then you don't have a whole lot of space in between the spine there, or the vertebra right there. On the right-hand side picture, you know, the upper levels don't look too terribly bad. We get down to L5 and S1, and you'll notice there is a significant loss of height right there. It has slipped forward just a little bit. And if you'll notice right here, there's a fairly significant spur coming off the front of the first bone of the sacrum, and then one on the back side on L5. Well, this is actually a picture of my back. And this picture is probably 5 years old now. And so I include this picture to let you know I stay active, I exercise, I can jog if I want to. I don't always do as much as I should. However, this is a significant finding, and absolutely if a surgeon looks at this, there would be justification for them to go in and do surgery on that. However, because I can manage my pain, I manage my first level of healing, which is the intense pain, keeping that knocked down. I maintain good range of motion and flexibility, and I maintain good strength. Then I'm not having any physical issue here. I've dealt with the mechanical issue, and so I can live with this. And the take-home message is, again, when we look at imaging, we have to be careful because we're not treating this picture. We're not going to treat this picture. What we're going to treat is the symptoms that a person is demonstrating. Is there weakness in the foot or the things like that going on? That's what we need to be focused on. So these folks, also the most common level of stenosis also is L4, L5. Now mine was L5, S1 because mine started as a bulging or a herniated disc. And then over the years, arthritis set in, and then mine turned more into now the stenosis or the arthritis. So if we take that same number of people, take 100 MRIs over the age of 50, and we'll talk about those numbers in a second. So again, that disc is going to shrink with age. Nobody is taller now than we were in our 20s or 30s. We always are going to get a little bit shorter. These are also the folks that have the grocery cart syndrome, and we've all seen them, and a lot of us have done this. You're pushing the shopping cart around Walmart or wherever, and you know the back starts to hurt. So what do? You cross your arms, you lean over on it, and it gives you a little relief. Well, it opens that space up a little bit. And so here, again, the MRI, 100 random folks, these 80 to 95% are going to have stenosis. And again, that 80 to 95% are not going to have any symptoms. So they've got this issue going on imaging, and it sounds terrible. However, they're not having any problems going on. And so again, let's make sure that when we're talking about symptoms and imaging, that we're differentiating what is physically manifesting itself versus what's showing up in a picture. And so the third cause of back pain is the sacroiliac joint or the SI joint. So if we have 5 blocks stacked one on top of the other, what would you think would be the most important one to keep this stack standing up tall? Top one, middle, bottom? Well, I'll go ahead and answer that for you. The most important one to keep those blocks standing upright, it's the bottom one. And the reason for that, and that's, let's call this is L5. This is your very bottom vertebra. And it sits right on top of the sacrum or your tailbone. Together, those two are the keystone of the entire body. So around that are our pelvic bone or our hip bone, if you will. That's that bone that you feel that if you're a man, your belt tends to go right below that bone. Female, if you're wearing a belt, tends to go right above. And so all of the forces of the body coming down are transmitted through these two areas. So this bone is called the ilium, and then this is the sacrum. So all the forces of the body travel through that. And so when there are problems there, to either side can create a lot of pain locally in that area. So what is the age for this? Well, this can be anybody. This can be, I've seen as young as 13 years old and as high as 85 plus. Full disclosure, I myself deal with pain and problems from the second part of the arthritis, the stenosis, and this sacroiliac problem. So I'm a number 2 and a number 3. And more than likely, most of us are dealing with more than one type. Either a younger person is dealing with a number 1, which is the bulging or herniated disc. They may just be that alone. More than likely, they may have a little bit of this sacroiliac joint as well. If we're a little bit older, then odds are we might just have some arthritis. Good odds we may probably look at some arthritis and some SI joint as well. So what causes SI joint problems? Well, it can be from a fall. It can be from trauma, such as a motor vehicle accident or car wreck of some type. Very frequently in the female population, I tend to see this in folks who may have had a little bit more challenging of delivery and labor. With that, the ligaments that hold the pelvis in place to the sacrum itself, all that holds it together is a big series of ligaments, and there's no muscles that cross those joints, so it's just ligaments that hold it in place. And so if during the birthing process, the body releases a lot of hormones that relax those ligaments to open up the canal for giving birth. And if there's a lot of pushing going on, then that can help that shift a little bit. And so I do see that a lot in my mothers who have had challenging deliveries. These folks tend to have increased pain with sitting and position change. And I do this. If I was giving a live seminar, you would see me walking around and shifting and moving and doing a whole lot of stuff. So folks with SI joint problems, they're shifters. We move around and we keep moving. One of the worst things that I can do is stand in a line for an extended period of time. That creates just a lot of issue, a lot of pain for me. And these folks, the pain can wrap around to the groin and thigh, or it can go out to the side of the leg. More often, we tend to see that it stays very localized right in this area. If there's some other stenosis or things going on, then it can follow these pain guidelines here. In this case, because there's some instability in that joint, the leg can actually feel heavy. It's not that it's weak or painful, it just feels a lot heavier than the other side. So we talk about imaging. The bad thing about the SI joint problem is you really can't get an X-ray or MRI or CT scan and issues in the SI joint show up. Now there can be tumors and lesions and things like that would show up, but for the majority of us, it is simply a slip or just a poor alignment or just an inflammation in these two joints that create the problem. So these don't normally show up on X-ray or MRI. And as a clinician, if I'm treating the low back and just not having good success, odds are it's because I didn't take a look at that SI joint. It is very frequently missed during traditional treatment. So that's one of the big reasons why I look at the SI joint quite a bit whenever I'm dealing with low back pain. Interestingly, 70% of people that have SI joint problems, it's because they have a right forward rotation of their pelvis on their sacrum. So the top 3 common causes of low back pain and sciatica is the SI joint or pelvic problems. And there you might have pain while you're sitting. It can be stenosis, degenerative disc disease, or arthritis. You have pain when you're standing or walking. Or the third, the herniated disc, is you have pain when bending forward. And again, this tends to be a younger person problem. This tends to be an older person problem. And then the SI joint can be anywhere. It can be at any age. So what does successful natural treatment look like? Well, normally in a workshop, I'm going to have some folks around and I'm going to bring an audience member up and we're going to demonstrate and go through some hands-on treatment. I'm a big believer that as a clinician, if I'm not putting my hands on the body and moving things around, in this case, either the spine or the pelvis, then I'm probably missing out on a lot. So if you're being treated somewhere and they're not doing some hands-on treatment, you might want to consider what's happening. Passive approaches just won't get there. So you definitely need some strengthening exercises to stabilize the spine and the pelvis. So flexibility is incredibly important. The homework that I give for patients, there's usually 4 to 6 different little stretches and strengthening procedures to go through that are incredibly important for maintaining that. Again, the stretching is a big key to it. The hands-on PT is always to deal with that first level of healing. We've got to come up with some way to knock that pain way down. Stretching and strengthening definitely to restore movement, restore range of motion, and the strengthening definitely the piece to get us back full on to what we want to be doing functionally in our daily lives. And so in my case, successful natural treatment looks like I'm also a big advocate in dealing with that first level of healing of either dry needling or a class 4 laser. A class 4 laser is a high-powered laser that we can, again, some people are very phobic to dry needling and to the other types of treatment that we can do. And so the class 4 laser can really get in and create an analgesic effect and knock down a lot of that pain that we're dealing with. But some sort of a little kick to knock that pain down a little bit further, whether it's dry needling, class 4 laser, and on the hands-on PT, in some cases it may be a manipulation, it may be an adjustment that needs to be done. But this is basically what a good, successful, natural approach to dealing with the low back and sciatica looks like. From time to time, there are people that there's just not much we can do to eliminate that initial pain symptom. For those folks, traction or decompression can be a big tool to help relieve pressure on the spine. Maybe 1 in 20 people fall into this category. The majority of time, we can do some of the other things, but in case everything else, nothing will make that pain diminish. Sometimes the traction again or decompression can be a big plus to diminish what's happening. So my offer, let me see what I've put up together here. So normally I'll offer a free consultation to my workshop attendees if they've taken the time to come in and watch what I'm doing and listen to me ramble and talk. Then if they want to come in and have a free consultation, I'll be glad to do that. What you get with the free consult is we'll look at certain movements. I'm going to feel your back to determine what's causing your back pain, your sciatica, and is there something that can be done to heal it naturally. I'll give you some tips. At the end, if you decide you want my help, then so be it. I'm not going to try to sell you on it. Whole goal is to give you information on what's going on and what you could do to handle it. So a little bit of difference between a free consultation and a full physical therapy evaluation. So a free consultation, we're going to try to so we're going to take about 15-20 minutes. We stay fairly busy. And so I don't do lots of these, but we will do it 15 to 20 minutes to see if we can determine a potential cause. You know, is it the herniation? Is it stenosis? Is it the SI joint? And then we'll talk about what successful treatment might look like for you. On a full physical therapy evaluation, here we're going to take 45 to 60 minutes, and we're going to really dive into what's going on. We're going to identify the cause. After that, we're going to go ahead and apply successful treatment. So we're going to tackle that stage 1 of healing, of really knocking that inflammation and that pain down. Then we're going to go ahead and set out a plan of care to treat your condition. I will work with you and we'll figure out what this is going to look like. There are times when we want to get into dealing with the back or any condition and do one magic little thing and it knock the thing out and you be good forever. And sometimes that does work. There are some people that I would just see once or twice. But I'll be honest, taking care of a back condition is a lifelong endeavor. And so taking 3 to 4 weeks of some fairly intensive therapy to again, nail down those three levels of healing can be very important to really get that pain under control and to give you the tools to get rid of it and take care of it and manage it permanently. So I have 10 slots available. I have some slots available for the webinar. What I'm going to say is if you do have questions, here is our location. We've got a location in Weatherford and then a location in Mineral Wells. Here is my email address. There's our web address. Whatever platform you're watching this on, there will be a link back to us. If you have questions about this information, or if you want to talk about what treatment might look like for you, or if you want to schedule an evaluation, be glad to do that. Feel free to reply